A young mother pushed her way into my consultation room at the Kelukim Hospital in Angola, a nation in southern Africa. In her arms, she held a child, and she shouted to me, "Oh, doutor, por favor, ajude-me, o meu filho está bem doente." "Doctor, help me, my son, he's so sick." I immediately came over to her side, and she showed me Ezekiel. Little boy, about 3 years old, he lay limp in her arms, his eyes half open, and he was gasping. "Come with me," I said. And we scurried down the hallway to the little emergency center where I gave Ezekiel oxygen and an IV antibiotic. But it was all tragically late. His breathing continued to get worse, and so I put on a face mask and I used a bag to push oxygen into his lungs. But nevertheless, his heartbeat slowed and slowed and stopped. Why did little Ezekiel die? Why do so many children throughout the low-income world die before even beginning first grade? Now, clearly he had pneumonia, but it was his circumstances that made him at such great risk for that disease. Angola is a nation of great poverty, very poor primary education, very little modern medical care. His illness was just evidence of that. At the outset of the COVID pandemic, there was a lot we didn't understand about the disease, but one fact became clear very quickly. This was a disease that was most likely to kill those who were poor, those who were disabled, those who were minorities, those without good medical care. We also concluded early on that no one would be safe until everyone was safe. Now, this is true of a highly contagious disease, but it's also true of most health problems. No one is safe until everyone is safe because the circumstances surrounding the person influence whether they will survive or not. Nowhere is this more glaringly obvious than in disasters. In 2005, Hurricane Katrina struck New Orleans. It was forecast 5 days in advance to make landfall, and yet when the storm struck, there were still 60,000 people in the city. Who were those 60,000? They were the poor, the disabled, the chronically ill, the most vulnerable people of the city, and almost 2,000 of them perished. So, in retrospect, why was New Orleans such a catastrophe? Well, first of all, it's a city built below sea level. The dikes that guard the city from the ocean were not designed for a full-force hurricane. The evacuation order came less than a day before the hurricane struck. And the emergency response system was based on cell phones. The hurricane took out all those antennas. So 5 years later was the Port-au-Prince earthquake, striking that capital city and instantly killing 300,000 people, the population of Omaha, Nebraska, dead. Made 1 million people homeless, the population of Dallas proper, out on the streets. Doctors Without Borders was there, and they wrote, "This is like working in a war zone. We don't have morphine to manage our patients' pain. We can't accept that airplanes carrying life-saving supplies are being turned away while our patients are dying." Why were the planes being turned away? The airport is very small in Port-au-Prince. It was damaged. It was already filled with airplanes. So in retrospect, why was this such a catastrophic earthquake? Port-au-Prince is filled with very vulnerable people. The emergency response and the medical care system, marginal at best. And most of the construction is from concrete. Now, some of you have experience making concrete. You take sand and gravel and you add cement that holds it all together. Well, when cement is in short supply, it's very tempting to just add a little more sand and gravel. Add some shaking to that, and the whole thing collapses like a dry sandcastle. But in both of these disasters, the response was amazing. Thousands of volunteers within hours were lending assistance. We as a world are fascinated with rescue. I grew up watching MASH, TV series based on an Army medical center during the Korean War. The characters are intriguing and hilarious, but periodically they stop the comedy and they rush to the operating room to save the lives of these soldiers who were injured defending your freedom. We loved MASH. 110 million people tuned in for the final episode. Well, soon thereafter came ER, same kind of TV series but set in America. And then a number of knockoffs. Chicago Med, Grey's Anatomy, even Off the Map, handsome medical missionaries saving the world. Well, this is all laudable. Outside every medical center in the United States, there's a sign like this. It says, if you have an emergency or you are in labor, you have a right to care at this facility. You cannot be turned away. It doesn't matter whether you have insurance or not, whether you can pay or not, we will care for you. Now, if you have a chronic health condition or you need preventive care, that's not necessarily covered. But if there is an emergency, we've got your back. Now, there's a downside to this emphasis. Rescue is often not successful, often very expensive, and we could also surmise that a predictable, repetitive need to rescue people is short-sighted. So what's happening in this image? People are being directed towards danger, directed towards the cliff. They're predictably falling off, landing on the earth below. But wasn't it thoughtful of someone to put a hospital right there, pronto, ready to provide care for these people? Well, the challenge is to move beyond a disaster rescue mentality to one that builds durability and resilience and strength within individuals and within their entire communities. Metaphorically speaking, to move from building our homes on sandy beaches to building our homes on rock and firm foundation. This is the idea behind the World Health Organization definition of health. It reads a state of complete physical, emotional, social well-being, not just the absence of disease. Now, this is a little utopian sounding, but it's built on the fact that physical health is connected closely with all the other pieces of society. For example, every nation in the world that has a really great economy has a pretty good healthcare system, and vice versa. The question of the night is, what do we do about the world's most vulnerable people? How can we build strength and durability among them? Now, as I say this, we have to remember that there are vulnerable people everywhere. Every major city, no matter the wealth of the country, has got those who are elderly, disabled, non-dominant language speakers, chronically ill. Everything we're talking about is on behalf of those individuals as well. I teach at the Institute for International Medicine. And in my courses, I often refer to the Human Development Index. This was created by the United Nations as a benchmark to measure human well-being. And it measures just three things: physical health, measured by life expectancy; access to knowledge, measured by years of completed education; and standard of living, measured by personal income. Now, the three of these were chosen because they're rather easy to measure, and they also contribute to one another. They rise and they fall together. Let's touch on them one by one. First is access to knowledge. Now, you and I know intuitively that better educated people live longer, have fewer health problems. That's generally true. The actual objective evidence from this comes from the nation of Tanzania in southern Africa. And researchers found that people with just a 4th grade education in any given year were 3 times more likely to die compared with those who had a 10th grade education. Controlling for all the other factors, being educated was protective and life-saving. Now, what can you and I do to promote education in our communities? I constantly urge young parents to read to their children. Early on, help your children develop a fascination with books and with learning and exploring. I urge teenagers to stay in school, do well in school, find some subjects that they're really passionate about, and even consider careers as teachers and educators. At the Kalukim Hospital, we're surrounded by a community that has many adults that cannot read and write. So in the afternoons, we open up our classroom and we invite all the adults in for literacy classes. So they'll spend an hour and a half learning to write the alphabet and to spell their first words and to form sentences. And over a period of months, their confidence grows, their job prospects grow. Adult literacy is part of our comprehensive approach to improving the health of the entire community. The next element of Human Development Index is income, standard of living. Now, poverty is closely related to a myriad of health problems. The very best book on this subject is The End of Poverty by Jeffrey Sachs. And in The End of Poverty, he argues that agrarian societies, first of all, need enough food. They need modern fertilizers, modern seeds, and as food becomes more plentiful, then not everyone has to work in agriculture. They can begin to diversify their economies. They can start businesses, they can do services, they can do manufacturing. What's happening in this image? Who are these people? What are they doing? Some of you have seen this for yourselves. They're waiting for water. Now, there's a lot of children here. Shouldn't these children be in school? And how about these women? Don't they have something more productive to do? The provision of water is important, not just to prevent diarrhea diseases. It's also important for children to go to school, for women to be able to start businesses. In the community surrounding Kalukim Hospital, we've dug deep wells. They go down 100, 200 feet deep, and water pumped out from that level is drinkable. Therefore, our children are in school, our women are starting businesses. It's another piece of our comprehensive approach to improving the health of the entire community. And now the third element, physical health. Now, a variety of interventions will make people's bodies healthier, but our resources are always insufficient. Not enough personnel, not enough money, not enough supplies, and so we have to focus our healthcare interventions. And to do this, we begin by measuring the gravity of various health problems. The measure we use is called the DALY, the D-A-L-Y, the Disability Adjusted Life Year Lost. And the DALY takes into account not only what someone dies from, but how old are they when they die. And so the death of a 3-year-old from pneumonia has much greater weight than the death of an 83-year-old from the same disease. So which are the leading causes of life years lost in the world's 50 poorest countries? Number 1 is pneumonia, followed by diarrhea disease, followed by malaria, and then birth complications. All of these affect children primarily. And then behind each of these diseases, there are risk factors, predecessors, make people more likely to develop the illnesses that kill them. So what are the leading risk factors for death in the world's 50th poorest nations? Number 1 is malnutrition, followed by unsafe drinking water and unsafe sex, hypertension, diabetes. As we intervene and reduce these risk factors, we also lessen the likelihood that someone will develop a lethal disease and die from that as a result. Now, if you start a health project, ideally, you'll get to know your community. You'll go door to door, you'll ask people, what are your health concerns, what are your resources, and you'll create a plan that's appropriate for that community. But in broad strokes, in the world's lowest income communities, the most effective interventions are nutrition and breastfeeding, safe drinking water, well child care, vaccinations, management of hypertension and diabetes. Very, very effective. In Angola, we have a lack of health leadership. Physicians, for example, don't have much opportunity to do anything beyond medical school. No residencies, they just go right to work. So we've created a 2-year residency program where they come to us and under the watchful supervision of our faculty, they develop their skill, they develop their vision. The curriculum we use was developed by the Institute for International Medicine. We're a graduate school equipping healthcare professionals and profession students with the unique skills necessary to serve the world's most forgotten people. Our board of directors and our faculty are followers of Christ. We rely on Christ for the security and the vision that we need to live day by day. And we express this through working diligently on behalf of humanity. We offer courses designed to fill the gaps in traditional medical education. For example, courses in tropical diseases and in disaster management. We offer hands-on skills in newborn resuscitation and trauma management. We offer service experiences with our faculty in 25 nations. And our premier offering is the MIH, the Master's Degree in International Health, which takes those elements and adds epidemiology and scholarly research. It's a credential that shows one not only has a good heart, but has backed it up with diligent study and qualification. Back at the Caloocan Hospital, one of our young resident physicians came to me and he asked if I would examine a patient with him. So we went to the ward and he introduced me to Antonio, a 4-year-old boy. Antonio had been coughing and had fever. And so I examined the child and I confirmed his diagnosis of pneumonia. And so I turned to the young doctor and I said, "How are you treating him?" And he replied, "Well, hours ago I gave him his IV antibiotic and I gave him oxygen, but he's better now and he doesn't need it. And I gave him prednisone to treat his wheezing." "Well done," I said. And then I looked around the room. There was his father. His father is in our literacy class. And his mother, she's a merchant in the marketplace. Little Antonio survived. His parents were educated. They had some income. He got prompt, good medical care. He's an example of the advantages that occur when we build strength within societies. And that is the challenge, to move away from focusing on disaster and rescue to strength and durability. It is true, no one will be safe until everyone is safe. Join me in working diligently to make everyone safe.